Okay, so welcome everybody. Thank you for being here with Colorectal Cancer Canada. We are going to be exploring left and right-sided tumors this evening. Clinical insight and a question and answer period with Dr. Scott Berry, who many of you have spoken with or heard of. Dr. Berry is a medical oncologist, professor, and head of the Queen's University Department of Oncology. He's the medical director at the Cancer Centre of Southeastern Ontario at the Kingston Health Sciences Center. Dr. Berry is an active participant in clinical research in gastrointestinal cancer. He is the co-chair of the Gastrointestinal Disease Site Group of the Cancer Care Ontario program in evidence-based care. So it's our absolute privilege to have you here, Dr. Berry. Welcome.
Thanks so much, Hannah, and thanks to you for inviting me. Thanks to Colorectal Cancer Canada for hosting this tonight. I'm really looking forward to speaking on this. I've, with my colleagues from across Canada, put a lot of work into looking at this question and thinking about how it impacted the lives of patients. And really, with Colorectal Cancer Canada, we tried to advocate together to make sure that patients had access to the best therapies. So I'm going to share my screen now, and I'm going to try and keep my part of this as brief as possible, with the idea that I'd like to have as much time for questions as possible. And so the title of my talk is, Should Primary Tumor Location Impact Our Treatment of Metastatic Colorectal Cancer? As Hannah mentioned, I'm from Queens and Kingston. It's been a couple things. It's been very cold here, but it's a little warmer today, going to be a little bit warmer over the week. I know people across the country are still managing through Omicron. And we were unfortunate in Kingston to be one of the first places where Omicron started. Things there seem to be easing up a bit, and I hope everybody is managing okay and managing through yet another wave of COVID. But I think hopefully things are going to be getting a little warmer. COVID's going to be fading into the background, and we can look forward to a better spring and fall. So just in terms of what I'm going to be talking about tonight, I'm going to talk a little bit about anatomy, because this is about right and left-sided tumors, so important to know what we're talking about. I'm going to talk about some of the clinical characteristics and symptoms of tumors as they relate to the side they originate from, because those can be somewhat different. I'm going to talk about whether tumor side impacts on the prognosis of colorectal cancer, and some of the work that's been done there, and some of the work I've done with my colleagues from Queens in that area. A little bit about the biology as it relates to tumor side, and how that might explain some of the things that we're going to be describing tonight. And then most of my talk, though, is going to be focused on metastatic colorectal cancer and answering the question, does tumor side predict value of different colorectal cancer treatments? Because I think that's where most of what I want to talk to is about tonight. And I will be talking a little bit about non-metastatic colorectal cancer when I talk about prognosis. So most of you, or many of you, will know where the colon sits in your body. But in general, this is the right side of your body where the liver is. This is your left side of your body. And this is the start of your colon, called the cecum. Appendix comes off there as it starts from the small intestine. Ascending colon goes up to the liver. This is sometimes the liver. The description is Hepatic, so this is sometimes called the hepatic flexure, this bend. This is called the transverse colon as it moves across your body to the left-hand side. This is called the descending colon as it comes down. This sits right in front of the spleen, so this is called the splenic flexure. And then finally it ends in the rectum and anus. So that's just basic anatomy, but it's important to orient ourselves because then I'm going to go to this more stylized diagram and talk a little bit about how the right and left-sided colon are defined and some of the anatomic differences. So just to let you know, most people define the right and left side right about here at the splenic flexure, just at the beginning of the descending colon where it starts to drop down in your body. And then, so all of the blue would be left, all of the green would be right. It's really not, as we'll see, especially when we get to the biology, it's not a hard cutoff, but these are the definitions that we use. Left-sided colon cancer is more common. About 2/3 of colon cancers arise on the left side, about 1/3 on the right. I think it's important to know that these are, even though the colon is considered one major organ, when they develop in the embryo, the right side of the colon comes from an embryological pre-organ called the midgut, and the left side of the colon comes from an embryological origin called the hindgut. So they actually develop differently in the embryo. And I've talked to my colleagues. I'm a medical oncologist, so I don't do scopes, but people, the surgeons and endoscopists who do scopes through the colon do notice that when they pass this part of the colon, things look different, different shape. Even though for a long time we considered the colon one big organ, there are differences in how it arises in the embryo, the number of colon cancers that arise, and as you'll see, some important biological differences as well. So in terms of the prognostic value of the primary tumor location, does the site of the tumor impact on how well people do with chemo, how well people do with colon cancer? And there is this large systematic review and meta-analysis, and this is a way of looking at multiple studies, combining the data from multiple studies. And this group, this is published about 5 years ago now, led by Dr. Petrelli, looked at 66 studies and more than 1.4 million patients. And this is actually one of the largest systematic reviews and meta-analyses that I've seen. The median follow-up of patients on these trials was about 5 years. So that means that most of them, about half of them, had been followed for at least 5 years. And this large meta-analysis showed that the left-sided primary tumors do better. They have about an 18% reduced risk of death, and that they concluded that left-sided colon cancers have a better prognosis. And when they looked at this didn't matter whether it was early stage cancer where it hadn't spread, stages 1, 2, and 3, or whether it was metastatic cancer when it had spread, stage 4, that regardless of the stage, and they also corrected for a number of other important factors, left-sided colon cancers appeared to have a better prognosis. Now, about the same time, Sophia Cream, who's now a medical oncologist in Calgary, but was training here at Queen's with one of our health services researchers, Chris Booth. We did this study looking at Ontario data. When we looked at association between prognosis and side of the tumor, we looked at a much smaller number of patients, but these were all all Canadian patients from Ontario. And when we looked at 6,000 patients, more than 6,000 patients whose tumors hadn't spread, tumor side was not associated with overall survival. In fact, so our data showed that it did not impact on prognosis, but so there is some controversy. However, when you have a meta-analysis of 1.6 million people, that probably overrides the local data, but I wanted to show some of the Canadian data. So what about, so what are some of the other differences? I'm going to talk a little bit about the clinical and biological variation based on the primary tumor location. And in terms of clinical characteristics, right-sided colon cancers occurs more commonly in women, and it occurs more commonly in older people. So people with right-sided colon cancer, more females and older folks. In terms of where these tumors spread, right-sided tumors tend to spread to the surface of the bowel. This is the peritoneum is a glistening lining of the small and large colon that coats and covers all of the bowel. And right-sided tumors have a predilection to spread to the peritoneum. Tumors that spread to the peritoneum can cause a lot of problems with bowel mobility. So people will become nauseated and have vomiting. If the tumors advance and start to press on the bowel from outside on the surface of the bowel, they can cause symptoms of tumor blockage, abdominal bloating, more nausea, constipation, etc. So differences in where it spreads and the symptoms that are caused based on the side of the tumor. Left-sided tumors spread more commonly to the liver and lung. Liver tumors cause pain in the right upper side of the abdomen, can cause jaundice because of liver dysfunction. And lung tumors can obviously cause a lot of shortness of breath and breathing difficulties, cough, etc. So these tumors vary in the types of patients. Older women are more likely to have right-sided colon cancers happen more commonly in women and older people. And they also differ in where they spread and the symptoms that they cause. So one of the questions is, why are these, again, why are the right and left-sided tumors different? And the short answer is, we don't know. But there are some really brilliant scientists looking at this, and John Laurie is a medical oncologist in BC, one of the really rising stars of oncology research in Canada. And I've had the pleasure of working with him on both educational and research projects. And this was a very elegant study where he looked at classifying colorectal cancer by tumor location and showed that things aren't quite as sharp. So again, you have this stylized colon here. This is the rectum, left side. You got it now, descending colon, splenic flexure, transverse, hepatic flexure, ascending colon, and the appendix. And what this shows is that the shading shows that the darker it is, this shows something called a hazard ratio for overall survival. So the darker it is, the worse the prognosis. And then all of these names here are biologic alterations in genes or other biologic characteristics of the tumor in terms of how frequently they occur. And the details aren't important, but first of all, you can see that there's no real sharp division. You can see that as you move from the rectum on the left all the way around, that things get darker. So as you move from the left to the right, the prognosis worsens, and people, as I've said before, but it's a fairly continuous thing that goes as you go around. The second thing you can see is that the colon, based on the biologic characteristics, is a very complex place. So you can see that some of the alterations, MSI is an alteration that predicts somebody's ability to respond to immunotherapy. Big over here, which means it's more common on the right, much smaller over here, meaning it's much less common on the left. BRAF is a gene that when it's altered can also predict a very poor prognosis for colon cancers. We now have targeted agents called encorafenib that can target this gene alteration, but you can see that it's very common on the right side, very small on the left side. RAS is another gene important for tumor production. You can see that RAS, the sizes are actually more similar across the spectrum. So you can see that although we'd like to say that this is right and left, we're actually talking about a very complex biological organ where a number of different biological alterations, genetic mutations, et cetera, happen at very different frequencies across the colon. And you can see some patterns. But unfortunately, even with all of this analysis looking at the genetic alterations, the biologic characteristics, nobody has really been able to say exactly why right-sided colon cancers do worse, have a worse prognosis than left-sided colon cancers. And they haven't been able to tell why they predict for responses to different types of treatment, which I'm going to be talking about next. The other thing is that the colon, it's not just the genetic alterations in the actual tissue cells that make up the colon, but the microbiome, the bacteria that sits in the colon is very different on the right and left-sided. Here, you can see that right-sided colon cancers have higher abundance of certain types of bacteria. Left-sided colon cancers have different prevalences of different types of bacteria. And we also know that there's something called invasive polymicrobial bacterial biofilms that have been detected on majority of the right-sided colon cancers, but only a small percentage of left-sided colon cancers. And it's likely that these differences in biological alterations in the colon cancer cells, along with the bacteria that's in the different parts of the colon, probably all have very complex biological interactions that relate to both the prognosis based on side and on some of the ways tumors respond to different treatments, but nobody's actually been able to put that all together. So I think that in a few years from now, we're going to have much more elegant analysis. And we won't be talking about right-sided and left-sided tumors. We'll be talking about tumors that have a certain biologic signature, including different mutations, different bacterial makeup, and basing our treatment decisions on that. But right now, that description between right and left, based on that division of the splenic flexure, is actually the best predictor we have. And there hasn't been, despite a lot of research on what the cause of that is, we haven't been able to figure that out yet. So the next thing I'd like to talk about, and this is where I'd like to spend a little more time on, because this is where some really interesting data came out showing that about the predictive value of primary tumor location. And this means, does where the tumor arises in the colon impact on how well it responds to treatment, or how the patient who has the tumor responds to treatment? Now, I'm going to give you, again, many of you, I'm sure, are well-versed in some of the basics of metastatic colorectal cancer treatment, but just for most people who have been diagnosed with metastatic colorectal cancer, it's spread from outside of the colon into another organ, whether it's in the abdomen, on the surface, liver, lung, or elsewhere. We'll get a combination of chemotherapy, traditional cytotoxic chemotherapy, and a biologic agent. In Canada, what that means for most people for many, many years now is that they get a combination of two chemotherapies, one called 5-FU, which is a drug I've been using to treat colorectal cancer for most of my 25 years as a medical oncologist. Irinotecan came on the scene in about 1998. This combination where the 5-FU is given through an infusional pump over 48 hours with irinotecan is called FOLFIRI. It has a French origin, but FOLFIRI is the name for that. And our traditional biologic agent, again, this is based on trials that were done in the early 2000s, were to combine it with a biologic agent called bevacizumab. Bevacizumab impacts the blood vessels that makes up a tumor. And again, in the early 2000s, we discovered that adding bevacizumab to chemotherapy improved outcomes, and this was our standard for many, many years. Now, this is a colon cancer cell, and I'm going to talk a little bit about another treatment pathway. And this is something, one of the ways that tumor cells grow is through different types of pathways. So this is a little receptor on the surface of the cell, and this is called the epidermal growth factor receptor. It's found on many cells like colon cells. And when this is triggered, it triggers intracellular genes, and you see RAS and RAF, which were on the previous ones. These are cellular pathways that eventually cause invasion of metastasis, proliferation, increased survival of cell. These are all things that promote cellular growth, less cellular death, and cancer. Now, again, in the early 2000s, we did discover that there are some monoclonal antibodies. Antibodies, as you know, are proteins that are generated by the body, and these can be produced by pharmaceutical companies now, specifically blocking this pathway. And we have two drugs, panitumumab or cetuximab. They both block this pathway, block tumor growth. And this particular protein, this RAS protein, is very important. And the bottom line is we found that from multiple trials in metastatic colorectal cancer, patients with mutations in that RAS protein, so abnormalities where it didn't function properly, and that's about half of people with metastatic colorectal cancer, because there was an abnormality in that pathway, they did not respond to panitumumab or cetuximab. Only tumors that are wild type, that's a genetic term that basically means normal, respond. And that's the other 50%. So about 50% of colorectal cancers that have a normal RAS protein or wild type protein will respond to these drugs, panitumumab or cetuximab. Now, this was a large trial published about 5 years ago. This was a North American trial that included more than 1,000 patients. And the question was whether chemotherapy and bevacizumab are standard treatment for many, many years, how it compared to chemotherapy and cetuximab, one of those agents that target the epidermal growth factor receptor pathway. And I was very fortunate to be the Canadian national lead on this trial, but it was done across North America. And it's the largest trial that ever looking at this question. And what it showed that is whether you use chemotherapy and bevacizumab, that combination of chemo and biologic agent, or whether you use chemotherapy and cetuximab that targeted the EGFR pathway, you had a very similar survival. And the median overall survival was 30 months, again, meaning that half of the people on this trial lived for 30 months. Now, one of the amazing things about this trial is that obviously we want to still do a lot better. We want to cure people with metastatic colorectal cancer. We're going to have treatments that have much longer median overall survival benefits. But when I started treating colorectal cancer in the last century, in 1998, outcomes were very poor, and people only lived on average for about a year. So in the last 25 years, we've made progress, still a long way to go, but we've almost tripled the median overall survival. Still need to do a lot better. But what this trial showed, and there was a European trial that didn't show exactly the same thing, but in our North American trial, whether you got chemotherapy and bevacizumab or traditional combination or chemotherapy and cetuximab, didn't matter. And the median overall survival was 30 months. Now, there are some trials of chemotherapy and panitumumab or cetuximab, and they compared that to chemotherapy alone. And when they did these trials, they found that by adding panitumumab or cetuximab to chemotherapy, it improved overall survival by 3 to 4 months compared to chemotherapy alone. Now, then they started looking at results by tumor side, though. And something very interesting came out. When they looked at patients with left-sided tumors, and when they looked at people who got chemotherapy with panitumumab or cetuximab, one of those two drugs, it improved actually overall survival by 10 months compared to chemotherapy alone. In the right-sided tumors, it had no benefit. So dramatic difference. And, I've been working in oncology now for 25 years, and there are very few treatments that we've instituted that were able to improve average overall survival by 10 months, almost a year. Still not as good as we'd like to do, but again, dramatic difference to the point where in the right-sided tumors there was no benefit. And when my colleagues and I saw these results, it was clear that, and this was, they analyzed a number of studies, and this was predominantly seen in the first-line treatment, and they analyzed all of the major studies that were done, and consistently across multiple trials, no matter what type of chemotherapy you used, whether you use panitumumab, whether you use cetuximab, the results were the same. Left-sided tumors, huge benefit. Remember, it was only 3 to 4 months if you looked just at everybody together, but 10 months when you looked at left-sided tumors. And in right-sided tumors, these agents didn't have any benefit. So we actually got together, and this is 5 years ago now. And I was actually at Sunnybrook then, but worked with my colleague, now my colleague at Queen's, Jim Biaggi, Bruce Caldwell from Dalhousie, Sophia Kareem was at Queen's at that time, now in Calgary, Alberta. And Bia Breja was a fellow from Brazil working with me at Sunnybrook. We worked with some of the top cancer experts from across the country, from British Columbia all the way to New Brunswick. And we also had a number of other GI experts there. And this was sponsored by the predecessor of Colon Cancer Canada, Colorectal Cancer Association of Canada. Barry was there, and a very ardent supporter. It was supported by the Canadian Association of Medical Oncologists and by oncologyeducation.com, an educational website that I helped to found. And so this was a very good representation of people from across the country, people who worked in academic centers, people who worked in non-academic centers, and a very good meeting. And we published our results in Current Oncology, the major Canadian cancer research journal, in 2017. And what we said is, based on the data, and we had lots of data at that point, that patients with left-sided tumor, RAS wild type, that have a normal RAS protein, should get chemotherapy with either panitumumab or cetuximab. And patients with right-sided tumors, or any RAS, or any tumor that had a RAS mutated or abnormal RAS gene, should get chemotherapy and bevacizumab, because in right-sided tumors, panitumumab and cetuximab don't work, and in RAS mutated tumors, panitumumab and cetuximab don't work. So we found, and we thought that this was very important. We circulated this report to provincial cancer agencies across the country, the national organization that coordinated provincial cancer agencies. And this data was used as part of a submission to the Pan-Canadian Oncology Drug Review. They reviewed this data in March 29 of 2018. And despite our very strong consensus review of the data and recommendations, they said there would be no specific funding for patients who had left-sided tumors who are eligible for these panitumumab or cetuximab because they had normal RAS proteins. They didn't fund it, which is very disappointing. Now, I'm going to put this down in writing. We have been able to, and now I believe in Quebec, these have been funded. In Alberta, it was funded. But in many provinces, which depend on the Pan-Canadian Oncology Drug Review, this has not been funded. In Ontario, we are able to still get this for our patients because there is a bit of a loophole, which says that patients who have a contraindication, who aren't eligible to get bevacizumab, the other biologic agent, because of something that prevents them, high blood pressure, susceptibility to bleeding. These are all things that make it very challenging clinically to give that drug, they can get panitumumab or cetuximab. And we've become, when I make sure that if I have a patient with a left-sided tumor that has a normal RAS protein, RAS wild type protein, I make pretty sure I find out that there's a contraindication, because I think it's really important that patients get that treatment. So through kind of creative use of this loophole, we can get this drug funded for our patients in Ontario. Patients in Alberta or Quebec have it funded. But despite the work we put into this, it was very disappointing. And despite the advocacy work that Colon Cancer Canada did, we were never able to get funding uniformly across the country, which is what we all hope for. So as I said, I've been talking for quite a while now. And at that point, I'm going to stop, and I am going to open things up, and I'm happy to answer any questions and things that weren't clear, things that you'd like to ask about the data, things you'd like to ask about the anatomy, and I'm happy to answer any questions.
So it just kind of nets out to be a win-win with some of those digital activities. So overall, I think we had some great discussions in all of the groups.
Not sure where that's coming from. That's not mine. Barry has his hand up. I do want to make sure to just go back to the loophole that you were talking about, Dr. Barry, after, because I think it would be really interesting to hear what you have to say about, maybe how patients can talk to their doctors. Again, not putting it in writing, but talk to their doctors about, finding a way to get this drug in first line, if that's something they think they can benefit from, but that it's not necessarily funded in that province. So maybe if you want to speak to that, or we'll go to Barry.
So I think that this has to do with education. And I think it has, so since my passion, I have done a lot of work in GI cancer research, but my other passions are education. So I have spent a lot of time traveling across the country, spreading the word and educating oncologists about this, to make sure that oncologists across the country know about this data, know about why they should be recommending this for their patients. And so that's been very important. I think that I know Colon Cancer Canada has been doing the same for patients, and this is part of that. So I think that having informed oncologists, informed patients, and being able to have that discussion, I have done, and I think a lot of other people have worked on this as well, to make sure that the word has got out that whatever the actual specific funding issues are in your province, you should be discussing this and looking for ways to offer that to your patients. So I think this is just another part of that, and I think it's making sure that you have that discussion. I would be surprised, even in provinces where this isn't funded routinely, where there isn't some way that the physician's not going to try and work through the mechanisms that are available and try and get this funded for their patients. But there's always work to do in terms of again, making sure both physicians and patients are informed, so that when they have that informed discussion about their treatment options, that this comes up for patients who have left-sided RAS wild type tumors.
Great. Thank you so much. I agreed. Education would bridge a lot of gaps, I think, in many areas. Barry, we'll go to you.
Thanks, Hannah. So, and thanks, Scott, for a really wonderful and easily, sometimes I wonder if even the oncologists would like an easy presentation like this, because it's so easy to understand. So really well done, and thanks for your continued work in this area and all the other areas, and what you've done not only with oncology education in the past and continue to do there, but in informing patients now in Kingston and leading the way across Canada for colorectal cancer patients. I just want to talk about a few things. So first of all, Unfortunately, in Quebec, it's although the health technology assessment body approved it, the government never negotiated. So we still have to use that contraindication to bevacizumab. And what that means is if a patient has hypertension, for example, that might just fall into one of the loopholes enabling a patient to get it in first-line treatment. But that's just one of the barriers. The other barrier is when a patient comes in, they have to know that they are KRAS wild type. They don't have the mutation. And in order to do that, you have to get a test, and it has to be returned in a timely manner so that before you get your first-line treatment, your first treatment, that the physician is aware of that. And one of the things that we've been working on across the country is to have equal access to what's called molecular profiling so that patients can get fast return of results, not just for KRAS, but for other things as well, for more in-depth answers to their questions. So this other barrier that I'm just noting, and it doesn't exist in all places, but in many places across the country, you have to be able to know your molecular profile status and certain things. For example, KRAS, BRAF, HER2, maybe you can talk about that, and in particular MSI, microsatellite instability, to get the right treatment in first line, meaning your first treatment. So now we have pembrolizumab, which is coming on. It's just actually the patient support program just ended on the 27th. So we're in a little bit of a hiatus to get this immunotherapy. And you have to know your microsatellite status as well. So all that, KRAS, MSI, all these other molecular profiles, this is a huge challenge. So that's my first question, I guess, if you will, because it sounds more like a comment. But the first question is, well, the first comment was that in Quebec, we still have this hurdle. The second one is, are we able to we are working together, our association, but in Kingston and other places, are physicians able to get these results fast enough in order to ensure the right first-line treatment? And then something else I just want to, if you can deal with a little bit, is the surgical aspects to this. When would somebody want to use these types of drugs, cetuximab and panitumumab, to avail themselves of certain surgical options, such as liver surgery? So that's what I have to say, and hopefully that was a little comprehensive.
So no, that's great. Let me start, and you'll remind me if I didn't answer any part of your question. Number one, and I do a lot of these talks for oncologists, and thanks. I'm hoping that I got this into a way that was understandable for non-docs, but I'm happy to answer any questions. But I did fail to talk about how you know whether a patient's tumor is RAS wild type or RAS mutated, and there are very powerful molecular tests now that can test for that very quickly. I have been very fortunate. I worked at two places, Sunnybrook and Kingston, and both places have kind of state-of-the-art molecular testing available. And when things were early on, some delays, but really get very rapid testing for RAS. And it's sister mutation RAF very quickly. RAF is more important for second-line treatment, but we tend to get that at the same time because they do it in the same testing panel. But I would say that I didn't go through all of the recommendations of our group, but what I realized when we had that group from across the country, and then I was at Sunnybrook, is that not all of the docs across Canada had access to that very rapid testing that I did. And so one of the recommendations in that guideline was also that the testing should be done in a rapid way and consistently across the country. So in addition to advocating for the funding, there has been advocacy for better testing as well. And again, that's been part of the educational package. I would say that right now, all of my patients get tested for RAS because it's immediately important for first-line treatment decisions. They get tested for MSI, and you saw in that diagram that it varies across the colon, but MSI testing is very important because it suggests for the people who have MSI high, which is about 5% of patients with metastatic colon cancer, have MSI high tumors, exquisitely sensitive, and get very significant benefits from immunotherapy, and pembrolizumab you mentioned. So testing for MSI is essential because for first line, and to know it as quickly as possible, because you want to know if somebody's eligible for immunotherapy, because you can be treated with immunotherapy alone and actually have better outcomes than with chemotherapy. So really important. All patients should get RAF. If it's easy to do it it's easy at the centers that are doing the molecular testing to get done at the same time as RAS. And those are the three things that I measure routinely, because those are the three treatments that have really good randomized data to support treatment. And I think that, it's really important that as we have data that comes out suggesting that treatments that are reliant on a certain biomarker, which is what we call RAS or RAF or MSI, that we need to make sure that patients don't only have access to the treatment sparingly, but you're right, have access to those tests. And I think you and I know that you and I have done podcasts on this, and I've done I did the podcast with John Laurie that was part of a podcast series. I think you did one in that series with Charlene Gill, but we've been trying to get the message out on that as well. In terms of surgery, so one of the things that came out, one of the things that we know is that patients who get chemotherapy with either of these drugs, really, panitumumab or cetuximab, have very high tumor response rates, really shrinks the tumor down. And when we're doing surgery for a tumor that's spread to the liver in particular, and because colon cancer is unique in that even after tumors have spread to the liver, they can be cured with surgery. The better job we can do of shrinking tumors in the liver, the better chance the patient could have for getting that tumor out and be cured. The problem is that there is there's conflicting data. There is one small Chinese study that says if you give chemotherapy and cetuximab prior to liver surgery for large tumors in the liver that were not amenable to surgery, then in fact what happens is the people who get the cetuximab actually live longer and have a higher cure rate. There's another trial from Europe, much larger trial. It was several hundred patients, where patients got chemotherapy both before and after their liver tumors were removed. Half of the patients just got the chemotherapy before and after, and half of the patients got chemotherapy and cetuximab. And in that trial, the patients who got cetuximab did worse. And even though we know that it shrinks the tumors down, and we don't really, that trial, we know the results, but we don't know why that happened. And that happens sometimes in science and medicine. I think that it's still controversial whether we can make routine recommendations to integrate these agents, panitumumab and cetuximab, for liver cancer surgery, because we have one large randomized trial that shows that we might be actually be harming patients. Now, I think what we need, like everything else, is better selection of patients. And I suspect as we get a better understanding of colon cancer and the biology, I suspect there are some patients who will have, very significant benefits from getting either one of those drugs, panitumumab or cetuximab, but giving it without giving it, to patients without understanding could cause harm. So I don't routinely recommend this. Now, I think every patient's different and unique, and I think that if we're discussing, we always have multidisciplinary tumor boards to discuss these cases. And I think in some cases, and again, in discussion with patients, and understanding the data that exists and it might cause harm. I think that that's a discussion with a multidisciplinary tumor board where expert surgeons, medical oncologists, radiologists get together. There may be some role, but I think as a general routine recommendation, it's quite controversial. And I think that it has to be very individualized. So those are my comments in response to your questions. I think I answered most or all of them.
I think you're getting the thumbs up.
Okay.
Perfect. Thank you.
Thank you so much. This is, incredibly interesting. I mean, it's not often we get to have these conversations and these insights into, into these areas. So again, thank you. It was a very compelling presentation as well. And I see Ian has a question. So I'm going to turn it over to Ian.
Okay, Dr. Berry, thank you very much. That was very informative. My question is on the microbiome, and to try and get an understanding of why the microbiome population would be different on the right side and left side. And secondly, do you evaluate the effects of treatment on the microbiome as you're doing the work to evaluate various drugs and treatments?
Yeah, so really good question. Why the microbiome is different on the left and the right?
Yeah.
I don't think anybody knows.
Good answer.
Yeah, it's true. Now, what we do know is that the microbiome, and this has mostly been done with immunotherapy, is that microbiome does have an impact on immunotherapy efficacy. And so, and you can imagine that if certain bacteria are present that are more stimulating to the immune system, and then you give an agent that stimulates the immune system to target cancer cells, that certain microbiome or bacterial profiles might work better with immunotherapy. I know there's interesting research going on in that area. That research has not, as far as I'm aware, progressed to late stage trials in colon cancer. But I think that either as a mechanism of understanding this sidedness or looking at how microbiome impacts treatment, including immunotherapy for colon cancer, is going to be an area of future research. This is not an area that I'm an expert in. I find it fascinating. I find it fascinating that why we have different bacteria living inside of us. We all have different microbiomes. Why the right side is different from the left, how it can impact on treatment. It's just fascinating. That's not my area of expertise, but I think that I know that this is really, I think the major areas where this is being looked at right now are the tumors that are really responsive to immunotherapy, like melanoma and lung cancer, because that's where it seems to have the biggest impact right now. But we're not there yet for colon cancer. So this is more observational as we try and say, we see that left-sided tumors do better. We see that left-sided tumors have dramatic differences in how they respond to treatment. We don't understand it. We see that the tumor sides are different in anatomy, embryology, microbiome, genetic makeup. We haven't been able to put that all together yet. So stay tuned. I think when we originally saw that data come out in 2017, and we were looking at it, I was kind of hoping by 2022 we'd have it figured out, but unfortunately we don't. I think it just goes to show how complex, and I show you that little diagram of, receptors triggered and triggers these little sequences of genes that causes cell proliferation, et cetera. It's obviously much more complex. There's interactions and things, that I think that are certainly beyond the understanding of a simple medical oncologist. However, there are people like John Laurie. There are people across Canada and the world whose specialization is looking at the biology and how it relates to the treatment relation. And we are integrating more and more of these into our future trials. So long-winded answer, but the answer remains the same. I don't know.
Okay, thank you.
Yeah.
So how's that for honesty? I love that. And, not knowing means that there's a perpetual search to know, right? And so your dedication to educating patients and oncologists is that much more meaningful, that you're really behind this cause and trying to figure out how and why, and therefore treatments will reflect that, hopefully in the future, and hopefully with the work that Colorectal Cancer Canada is doing, and that it will become reflexive testing. Biomarker testing will become something that is common across the board, regardless of province or institution. Clearly, it's a really important part of all of this. One thing, Ian, thank you for your question. One thing I just wanted to mention with regards to this is Maria, one of our program managers, put this in the chat, that CCC will be holding a webinar on microbiome and colorectal cancer in the next month. So keep your eyes out for that. And also, if you want, there's a optimistic trial. So www.optimistic with 2 C's.org to learn more about that. I actually wanted to ask you, Dr. Berry, just in terms of, and I'm sorry if I missed this, I don't think I did, but in terms of recurrence rates, left versus right, I mean, is there really any information that you could impart on that? What has a higher rate of recurrence, and maybe why?
Yeah, so as I was pointing out that in that really huge systematic review and meta-analysis, they looked at outcomes for left and right, and they did fairly detailed analysis of subgroups by stage. And imagine when you're dealing with more than 1.5 million patients, your subgroups are pretty large. And they looked at stage 1, which is tumors that spread a little bit through the colon cancer wall. Stage 2, spread all the way through the colon cancer wall but don't involve lymph nodes. Stage 3, that involves the associated lymph nodes. And stage 4, where it's spread. And when they looked at all those 4 stages, they didn't see any impact on recurrence rates. So it seemed to be across the board. When we, in our Ontario data, looked at just the stage 1, 2, and 3. We didn't look at stage 4. Sorry, in that big trial, whether they looked at stage 1, 2, 3, or 4, left-sided always did better. In our data in Ontario, when we looked at just stage 1, 2, and 3, side didn't seem to matter. There are other groups. I know that Hagen Kennecke, one of our former colleagues in Vancouver, now in Portland, Barry knows, the BC data showed that some of the stages did show difference, and some not. So, but that big meta-analysis that looked at more than 1.5 million patients showed that left-sided tumors always seem to do better regardless of stage, always had a better outcome, less chance of recurrence regardless of stage. Okay,
fantastic. Thank you for going over that. Anybody? Okay, Barry, your hand's still up, and so is Ian's. Is that more questions? Okay.
Mine's a new one. But I was waiting to see if anybody else had a question first. Dr. Berry put up a very interesting slide showing the different bacteria in the microbiome. So Maria put up that we will be doing a lay version of Optimistic, where we're patient advisors to the Grand Challenge Cancer Research UK international project on colorectal cancer and the microbiome. So we're going to have we're going to give a lay presentation with each of the researchers from around the world. But I just wanted to sort of comment, because you had something on the Canadian aspect. There are 2 labs, Rob Holt in BC and Alan Vercone in Guelph, actually working as part of this Grand Challenge. Emma's lab is working on the Fusobacterium that you had on the right side, I believe, of your slide. And we can show, or they're working on showing, that if you can either destroy or prevent the fusobacterium, you can perhaps prevent colon cancer by way of example. But even more interestingly, by manipulating the microbiome, you can perhaps make some patients receive immunotherapy better. In other words, if they were microsatellite instability, microsatellite stable, and they couldn't take immunotherapy, perhaps by manipulating the microbiome, you'd be able to do it. So Lillian Su at Princess Margaret actually has a metric trial going on at a clinical level already. And Rob Holt in Vancouver is working with vaccines and immunotherapy as well. So very interesting developments with the microbiome. Stay tuned, because we may be manipulating the bacterium in your colon instead of giving you drugs, chemotherapy in the future. So very, very interesting. We're also looking at both prevention, screening, so diet, things like that, how it might affect the screening. We're looking at both anatomical location and geographic location, where you are in the world, how that may affect screening, like our FIT programs, for example, across the country. So really interesting sort of parallels between, drugs and the bacterium inside, the good and the bad bacterium inside your colon, your large intestine. I just wanted to highlight that. We'll be doing that in a very lay fashion. You can go to optimistic.org, that's 2 C's at the end, and learn a little bit more about the project. And actually, it's a great encouragement. For one of our goals is to ensure that patients work on a basic research like this and participate in clinical trials as well. So I'm sure that's music to your ears as well, Dr. Berry. Just a little highlight of things.
Great. I'm glad I can learn, and looking forward to hearing more about how we can understand and manipulate the microbiome. We already know that for certain bacterial C. difficile infections, we can do stool transplants that can treat it. So maybe we'll be doing that. But anyway, I think it'll be interesting to see, and I'll have a look at that. I'll have a look at that site.
Okay, very
There's
interesting.
got to be other questions out here,
Yeah.
because I can ask questions the whole night. But we want to have what other people may want to ask. Iris, perhaps you have something that you, Iris is working on our patient education as well at Colorectal Cancer Canada. Iris, can you hear? I don't know.
Or we're putting Iris on the spot, one or the other.
Here she is. She's in Brazil,
Here,
so it takes a little bit longer to come through.
Thinking.
Anybody have any questions? I mean, feel free once we have Dr. Berry with us.
Maybe I'll ask one while people are waiting. So it's not so much as sidedness, but perhaps you can enlighten us a little bit about the use of pembrolizumab immunotherapy. Keytruda is the trade name for it. I'm sure everybody's seen it on TV on its use in colorectal cancer.
I think that we have one. So first of all, I'd have to say that, having been a medical oncologist for 25 years, the truly remarkable advances in, as I said, we've made some solid advances in colorectal cancer. We've tripled median overall survival. But in terms of, truly, transformative changes, immunotherapy and what it brings in terms of being able, not for people with metastatic cancer who were had a very short median survival with diseases like melanoma or lung cancer, are now essentially being cured, even if they have very advanced disease, including brain metastases. So there's no doubt that immunotherapy is an incredible tool. One of the, is that different types of tumors are much more immune responsive. So melanoma is kind of the prototypical. We've always known it's very sensitive to immune therapies. And, it has to do with its underlying biology. One of the unfortunate things is that in colon cancer, we've only been able to identify a subset, I said, of about 5% of patients who have these MSI high tumors who seem to be exquisitely sensitive to immunotherapy. And we know that if those patients get pembrolizumab instead of chemotherapy, they do much better. I'd have to say that one caveat there is that there are some patients with very rapidly progressing disease who probably need chemotherapy, not immunotherapy. So not the best treatment for absolutely everybody, but for people who have MSI high tumors, immunotherapy really is an advance. But the problem is it's only about 5% of tumors. And I think that one of the frustrating things has been in colorectal cancer is there's been a number of ways for, well, what about the other 95%? Are there ways of, combining immunotherapy with other treatments to make it work in those other 95%? Because what we really want is to see those types of really dramatic responses and benefits in people who don't have MSI tumors. And unfortunately, in colorectal cancer, that's been a little bit disappointing. We've combined it with different biologic agents. We've combined it with bevacizumab. There's a drug called cobimetinib that we used. And although the early studies suggested that they might make tumors that weren't usually going to respond to immunotherapy respond, once we get to the large phase 3 trials, they don't have benefit. However, there's no doubt that for patients who have MSI high tumors, and this is for any GI tumor, but for colorectal cancer, really good evidence now that they not only have a significant prolongation of life, but have improved quality of life because they're not getting chemotherapy and the tumors are shrinking, and they actually have improved quality of life, which is really important. So I think that there are some trials we're awaiting now. Does giving chemotherapy and immunotherapy together better in colorectal cancer? And there's a trial looking at that. There are different types of immunotherapy, and they're looking at whether different combinations of immunotherapy do better than just one drug, the pembrolizumab. We don't have data on that yet, but really right now, really important for anybody diagnosed with metastatic colon cancer that they have their tumor checked for MSI status, and that they do have an MSI tumor that they have access to pembrolizumab.
Okay, thank you. I think Ian has another question.
Yeah, Dr. Barry, is it standard practice that all people who submit with tumors have molecular testing done? Is that standard across Canada of all of the oncology centers?
So the short answer is I don't know. The long answer is I hope so. I think oncologists, the organization that I work with, Oncology Education, advocacy groups like Colorectal Cancer Canada, have put a lot of work into making sure that patients have access to, not only have access, but access to rapid testing. So that because if you're starting on your treatment, you want to know that you can have that information as quickly as possible. So the short answer is I don't know, but there's a lot of work, and I would be surprised. I think with the work that's been done, if there were major cancer centers where that wasn't available, there may be some centers where it may not be available very rapidly. And I will say that there is some data showing that even if there are some mild delays, we like to have that information back within 2 weeks. There is some data though that if there is a delay in getting that information back and a delay in starting the appropriate biologic therapy, that outcomes don't seem to suffer. It's clearly not what we want, but I think it can be reassuring to patients if they're at centers that don't have that testing. But I would say that Barry and I and a lot of other people across the country have worked very hard to make sure that those are not only routinely available, but routinely available in a timely fashion. And again, I think one of the things I've learned is that the education, we do a lot more educational events and work with our pathology team members now, because the sooner our pathology team members can know about the advances in therapeutics, they want to do the best for their patients and the patients they're serving, and they want to, they want to be able to get the latest tests and integrate them. So we've done a lot of work with that. But to answer your question, I don't have any data on how widespread it is. Barry, have you done?
Okay. So
Yeah.
just to follow up,
Yes.
in Kingston, what sort of size operation is the pathology molecular testing?
Yeah.
Like, are we
So
looking at 100 people or 10 people, or in Kingston at Queen's? Or
in Kingston, we're very lucky because even though we have a relatively, we have a kind of a mid-sized or smaller cancer center, our head of molecular pathology, Harriet Filotter, is the head of Cancer Care Ontario's molecular pathology team and really a national and international leader on molecular testing. So in fact, Kingston actually, for us to get our routine testing in Kingston, it's a snap. But that's because Harriet's here and, really advocates and has really led the development of not only standard testing, but actually novel methods to do things even faster and more cost effectively. So in Kingston, we're very fortunate to have somebody like Harriet.
Okay.
Wonderful. Thanks, Ian. Maybe Barry, do you want to speak a bit to the molecular profiling and access across the country?
Sure. So we actually, and we have our expert with us, Maria Elbizri is with us, who's our program manager on our program called Get Personal. And we surveyed, and maybe Maria can talk a little bit if we have some time. We surveyed 26 cancer centers across the country and looked at the turnaround times and all sorts of questions in terms of pathology. And we are also working with something called the Beat Cancer Coalition, which involves industry and cancer centers and companies that do next generation sequencing and all sorts of people engaged in molecular profiling across the country to argue and to actually, in some cases, give access to molecular profiling universally across Canada. So we're very concerned about the equity issue in terms of everybody getting access to this, not just in some centers. Of course, the major centers are getting faster access as this develops, but a couple of interesting things have happened. Cancer Care Ontario started to extend their reimbursement of certain molecular profiling, but there were some roadblocks that we learned along the way because although they reimbursed the profiling, not all centers had the pathologists available, the equipment available, or weren't able to follow up with CT scans, for example. So we have to look every time we make a change, make a request in health policy, at the whole ecosystem and how that's affected by it. Apart from just the straight cost of it, which is what health economists look at and governments look at, the payers look at. But one development along the way, and perhaps you can enlighten us a little bit about this, is, well, first of all, let's say that on molecular profiling, you're usually looking at tissue from your organ, so following a surgery or a biopsy, something like that, so they can examine under the microscope and make their determination, put it into the equipment to do next generation sequencing, for example. But that's not always a possibility. Very often patients come in to emergency, or they need to start treatment right away. They can't even have surgery. So something new and very innovative that started to come up is called ctDNA. So maybe Dr. Berry, you can tell us a little bit about ctDNA and the impact that may have in the future, or starting to have now in Canada and around the world.
Yeah, so I think circulating tumor DNA and these are molecular testing done on blood samples, liquid biopsies, are really important for a number of the reasons that you said. One is you can do it. You don't have to book a biopsy. You can just take a blood sample and get it done quickly. I think that here are the challenges. So first of all, circulating tumor DNA is just the detection of circulating. So if somebody's had colon cancer surgery and you do a blood sample and they have circulating tumor DNA in their blood, that's been very well demonstrated to be a very poor prognostic sign. And there are clinical trials happening all over the world, including in Canada, to integrate testing, using that type of detection to look at which patients should be treated after surgery, after rectal cancer surgery. Barry and I are working on a study right now called SOARING, which is CO31 at Canadian Cancer Trials Group, which is using circulating tumor DNA after rectal cancer surgery or rectal cancer treatment where we're trying to avoid surgery. It's being used in something called the DYNAMIC study, which is a Canadian-Australian study. So we're using that, just detecting the circulating tumor DNA to better determine which patients should be treated or not treated after, as part of a curative treatment scenario. Using circulating tumor DNA to look for those mutations, to look for RAS or RAF or MSI, is a little bit different in that there's no doubt that it can detect those mutations. What the work is being done on is to make sure that it can be done as reliably with the blood samples as it can be done with a biopsy. So there are a number of studies going on right now to make sure that these tests are properly validated, and because we're making big decisions with those results, right? Whether to give somebody panitumumab or bevacizumab based on whether they have a normal RAS or an abnormal RAS gene. So we want to make sure that the determination is correct. We know that the gold standard tissue biopsy that was used on the clinical trials is definitive. We're not always sure, and there have been some examples where when you do the liquid biopsies, they don't they don't detect it as accurately. So again, this is where we really count on our translational scientific counterparts. And there is not a trial being done, or very few trials being done right now in the colorectal or GI space or in the cancer space, where the liquid biopsies aren't part of the trials. Certainly in the colorectal cancer space, I don't think that liquid biopsy should be a part of standard care right now, just because they have not been validated, but should be part of clinical studies, are parts of important clinical studies. And hopefully those studies will, in a very short time, validate the tests so that we won't have to worry when you come in for your first visit, and we need to have those tests done. We take a blood sample, we can get RAS and RAF and MSI and whatever other biomarkers that become important as quickly as possible. But right now, they're not ready for prime time in colorectal cancer.
Okay, well, hopefully things will progress and the validation will come with it, because it's definitely a less invasive way of doing things. Anybody else have any questions or comments for Dr. Barry before we start to kind of wrap up here? Barry, you want to throw something else out?
For sure, for sure. Always an interesting topic to cover. We encourage patients to know about clinical trials as early as possible, but not just wait until a treatment has failed them continuously in second or third line, but really from the beginning to start to understand what clinical trials may be available. One of the problems that we have, and we're looking into, actually, we are working on this, I should say, is in clinical trial navigation. In most provinces, when the patient wants to know about clinical trials early on, or at any stage actually, but we encourage it early on, they only hear about the trials in their center and perhaps maybe just in the province, but not across the country. In Ontario, actually in Windsor, there's a program that's being started, which we're going to partner with them on clinical trial navigation, a navigator, an actual person who would work with the finders and so forth. So I was just wondering if you've had any experience with clinical trial navigation on behalf of patients, either at Sunnybrook or at Kingston, and what do you think about that?
So I think it's a really important topic. I think that I think that in a local community, so when I was at Sunnybrook, we served a community of medical oncologists that span the greater Toronto area and out to Kingston, down to Niagara, etc. And we had our local communication network to make sure that everybody really in Southern Ontario knew what trials were happening at Sunnybrook. They knew they could contact me, my partner Huge, etc. But it was a good community. It was good within that network. But you know, I would love to have for my patients a up-to-date electronic, accessible, where they could go in and get reliable, up-to-date information on what trials were available anywhere they felt they wanted to travel. Now, the issues are the Comet network in Comet had a clinical trials group and tried to keep it updated, but I found that that's always the issue, having the staff and not only the staff, but the willingness of the centers to provide the information to keep things updated. So routinely now, if I are looking for a trial, I will have I try and keep in touch with my colleagues in Toronto, Ottawa, in particular, to make sure that if my patients need a trial, they'll be able to go. I would say that in the United States, people will travel all over the United States to go for trials. I would have to say, and this is always going to be a personal decision, that traveling for clinical trials offer great opportunities for patients, to be part of testing new treatments. They almost always have the burden of more testing, more visits, etc. If you add on to that the burden of travel and extensive travel, I think that just has to be part of the discussion, right? Part of the risks and benefits of traveling. So, and I've even noticed in Kingston, some people are quite willing to go to Toronto. For some people, it's just an extra burden they don't want to take on. But I definitely think that, as with all of these things, having the information so that people can make that decision. Do I want to travel to Vancouver? I once had a patient who didn't want to fly, so he took a train to Vancouver so he could participate in a clinical trial there. God love him. But for some patients, that just would have been, So I think having a cross-Canada trials network that could provide up-to-date access for patients mostly, but also for oncologists who wanted to advocate on their behalf and know what was happening, to present that information. I think in Kingston, probably, I would imagine most people are going to want to stay in the Toronto, Montreal, Ottawa range. But if they knew, like you said, not right up front where trials were open and what trials were available, I think it'd be great. The other thing, Barry, is, as you know, things evolve very quickly. So you want to know things early, right? So you want to say, well, I don't want to wait till this treatment has stopped working for me and then decide. On the other hand, trials open and close very quickly. So you may, if you know about a trial, and then you're fortunate to be on treatment for a long time, even if you don't know about that trial, when it's time for you to avail yourself of that trial, it may have already been closed. So there's that balance that has to be struck. But I think that any initiatives that are going for, and there has to be ways of doing it, of rapid, online, up-to-date, cross-Canada trials network. It's something I've been hoping would exist. I've seen, early attempts at it with the Comet network. I'm glad to hear folks in Windsor are trying to do it, but it's really hard. It's really challenging.
It is hard, and it's not just the trial finders, the equipment, and Onco Quebec and QCRO in Quebec has got an amazing trial finder for Quebec trials. But it's really comes down to the individuals, the oncologists themselves, and willing to share. So one of the new developments that the Clinical Trials Network 3CTN in Ontario has put together, it's actually a national network, is a paper called CRAFT, C-R-A-F-T, on decentralized trials. In other words, having a mothership with satellite centers that can be done. And I think this is not in wide use in Alberta. It's happening, for example, to some degree. And there's some other centers that are beginning to do it, but this is something to look forward, to in terms of being able to participate in trials. Another novel approach that we've got started in Quebec so far, it's only in its early stages as meetings, is creating a community of practice among oncologists practicing in colorectal cancer, so they can not only talk about trials that are ongoing, 4 or 5 times a year, but start to share trials ultimately and refer patients. So a lot like the COMET in Ontario, but just using the clinical trial finder of QCRO, the Onco Quebec one, and get them to talk to each other. This seems to be one of the big barriers in getting oncologists to talk together. So in order to share, refer people to trials. So do you see this as a barrier in Ontario?
So I think it is a barrier, but I think it's one to easily overcome. And I think it's about, it's kind of what I was talking about, right? Like we had a community of practice, but it was very, not insular, but it was very contained. And so I think it's really an expansion of that idea. And these days with technology, I can see AI, being used to connect and help in those make connections. I think it is a barrier. I think it can be overcome. I think that I have heard of the triple CTN efforts to decentralize trials, and I think that's really important, right? Because we would often have situations where we tell patients, you can participate in the trial, but even in Kingston, and in Kingston, we're fortunate to have, we try and decentralize our treatment for folks in Napanee, Perth, Smiths Falls, Brockville, Belleville, etc. But they can't, generally can't participate in trials there. So I absolutely think that as a way, and in our region in particular, we have, we're one of the more rural populations. We have a very high elderly population, and decentralizing trials like that so that people could participate in trials closer to home would do a lot to reduce inequities. So in trial access. So I think that is a really important initiative.
I see Iris posted a question in the chat.
Yeah, and then we'll get to you, Ian.
Okay.
So I'll read this question out for you, Dr. Barry. So, hi, Dr. Barry. What are some of the ongoing trials in Canada that are exploring the association between sidedness and response to colorectal cancer therapies?
Yeah, we're not doing many trials because we feel that question has been decided. That I think there are trials looking at, and I'm not aware of any, but I think that a lot of the trials that are being done continue to look at, from the large trials that were done looking at, the big trials that were done looking at treatment, trying to analyze the blood tests and the tumor samples they had to figure out why right and left behave differently, and perhaps a better understanding that went beyond left and right. There's no doubt in my mind, I think there probably are some right-sided RAS wild-type tumors that respond to treatment with chemotherapy and panitumumab or cetuximab. We just don't know which ones. So we're not actually doing any trials to look at between sidedness and response, but I think there continues to be analysis of the blood samples and tissue samples we have to try and figure out why that occurs. But I'm not aware of any specific trials going on, because we think that based on the information we have, we've really answered the question of which side should get which type of treatment, but getting a better understanding of the biologic understanding of that's the important part now.
Okay, great. Thank you so much. Ian, we'll go to you. Your
Yeah.
question.
So I was just listening to you talking on the trials. Is the right and left side cytological differences the same for all mammals? And if so, do we use mammalian experiments to evaluate the drugs and the efficacy of the treatments?
That's a really great question, because we do a lot of our drug discovery in mice, and I have no idea. Very good question. I suspect not, because as you get into, like for instance, a cow's colon, right? Because they're ruminants and stuff, is much different from a human colon based on diet and stuff like that. But I have no idea. But as a model for looking at it, it would be interesting. But I that's great. I don't know the answer to that.
Okay, thanks.
Thanks, Ian. I actually just wanted to ask you a question about sort of follow-up following cancer treatments. Is there one of the patients had asked, is there a difference between left-sided, right-sided follow-up plans, given that one's more of a recurrence? Like how does the follow-up differ typically?
Yeah, I think that our understanding of follow-up has evolved as time and trials have evolved. And it's interesting. A lot of the questions have been around things like, for years and years, everybody got a CT scan and a CEA every 3 months for 3 years, and then every 6 months for 3 years. And as the data has come out, I think we understand now that we can probably do less of that without compromising outcomes, like that we don't have to be quite as intensive in our follow-up. So we've had questions on intensity of follow-up. We've had questions on who should do it. Should it be done by an oncologist or a nurse practitioner or a family doctor? And most of those have shown that it can be done by any of those folks quite well, as long as there's good follow-up plans. I think though, Hannah, because this data on prognosis has really only come out in the last 5 years, and follow-up trials take a long time to do. It's a good question. I have not seen that. I have not seen that integrated into follow-up plans yet. What I will say though, and it comes back to what we were talking about earlier though, is that we have started to think about the next generation, right? So I told you that circulating tumor DNA is a fairly exquisite and sensitive way of picking up residual colon cancer after resection. And I think that rather than side-based, I think we're going to be seeing a lot more treatment decisions and follow-up decisions based on circulating tumor DNA. So maybe that you don't get any scans done, but that you have your blood sampled every 3 months for circulating tumor DNA. And if we see any signs of that, it would trigger a CT scan. If there's no circulating tumor DNA, you may not get any CT scans. So I think that if there's circulating tumor DNA there, the trials are being done, you will get adjuvant therapy. If you don't, you won't. Those trials are being done. But it's a good question, interesting thought. But we don't have the data on whether different follow-up patterns would alter it. But I think we're on to the next stage, using those kind of exquisitely sensitive molecular tests for follow-up and treatment decisions.
Okay, sounds good. I guess, as maybe if it becomes more simplified, with these types of tests and less invasive, and then perhaps less costly, there's more of a chance that the follow-up would be,
I think that, the technology, right? So to do these molecular testing 10 years ago, and I'm exaggerating, took a long time and it costs a lot of money, right? What's happening, year by year is the technology is advancing and it's becoming much more sensitive, much more rapid, and much more affordable. The cost of doing the first human genome sequencing was, I can't remember, some millions of dollars. Now you can do it for $10 or something like that. So I think that we're going to see a lot more follow-up treatment decisions. Some of the work that John, Laurie, and I have been interested in is you can actually do testing of somebody who's on these drugs, panitumumab and cetuximab, and see people based on the mutations that arise. People become immune. You take them off the drug, and they become resistant, and then then these mutations that were causing a resistance fade, and you can reintroduce the treatment. And there's trials being done with liquid biopsies for that. Again, not ready for prime time, but I think we're going to be seeing a lot more, treatment follow-up decisions based on that type of analysis.
Okay, thank you. Actually, there's a very interesting question. I'm sure other people are wondering the same. So if you could just speak to the differences between what would be found in the ctDNA versus when they're testing for CEA and CA19-9. Like, this is not considered circulating tumor DNA. That's a different thing.
So CEA is a protein. So it's a much larger molecule, whereas circulating tumor DNA is just, really, as it suggests, small pieces of
residual DNA
from the tumor,
okay.
And it's just circulating free in the circulation, and so you need much more. Was much harder to detect, but now with the methods they have, CEA is relatively easy to detect because it's a protein, large, it can be detected with fairly standard techniques. But even now, circulating tumor DNA, and I think, so you can just look and say, obviously, if there's tumor circulating around in your blood, we used to look for actual cells, circulating tumor cells, but circulating tumor DNA is much more sensitive. But then you can look at the DNA and see if those mutations are there. But we know that even if there's circulating tumor DNA around without looking for specific mutations, that in fact, those are very important prognostic in their own right.
Okay. Thank you. Barry, on to you.
Yeah, I actually just want to follow up on somebody posted something in the chat and about their rectal cancer patients. So I thought maybe it would be a good idea to distinguish when we're talking about sidedness and the treatments with the anti-EGFRs, panitumumab and cetuximab, and distinguish that from the treatment of rectal cancer. Same rules apply, different rules apply. How does it impact the rectal cancer patient?
As far as we can tell, the rectum is just, we treat that as left-sided colon cancer. So anything from the rectum to the splenic flexure, just at the top of the descending colon there, is left-sided colon. So that would include the left-sided colon and the rectum. And but as John's little colon map showed, right, it's not quite that simple. That it's much more continuous without a sharp divider, and that when you start looking closely, the map starts to get pretty complicated, right? So, but a metastatic rectal cancer would be treated like a left-sided colon cancer.
But most rectal cancer patients, or often rectal cancer patients, will start with neoadjuvant treatment. In other words, prior to surgery. I noticed you used the word adjuvant before. Maybe we should explain adjuvant as well as neoadjuvant treatment. But many rectal cancer patients would start with Walpox as a neoadjuvant treatment, do radiation after that, and no surgery possibly. Would this mean that rectal cancer patients who are RAS wild type would start with a first-line anti-EGFR instead of FOLFOX and
Yes.
radiation?
So, so I think we're just talking about slightly different things. All of the data I presented on predictive is on metastatic colon cancer. So any of the treatments on early non-metastatic cancer, whether it's rectal or colon, and you're right, Barry, for rectal cancer, we give we give treatment before and after. Before is called neoadjuvant, adjuvant meaning an adjunct to the curative modality surgery, adjuvant being given afterwards. But those are to increase cure rates for early stage cancers that can be removed with surgery. Everything I've been talking about today has been talking about metastatic and prediction in metastatic patients. And what I was saying before is that it's controversial, but the first thing is none of these biologic agents have been shown to be of value in the neoadjuvant or adjuvant setting. So now it might be interesting to go back and look at some of those adjuvant trials and say, if you looked at it by left and right, all of the adjuvant cetuximab trials, for instance, were negative, and panitumumab trials with chemo. Maybe if we went back now and looked at them, I don't believe that's ever been done. So all of what I'm saying about these things have been demonstrated in patients with metastatic cancer. You know, if we're going to introduce and because we don't use biologic therapies as part of the treatment of early cancers because they haven't shown benefit, we don't integrate that same type of decision making.
Thank you. So
that
is very clear, and I hope that does help a little bit the person, Angie, I guess it is. So thanks, Angie, for that post. It's a little bit different. I know the question, the way I put it, than what's there, but I tried to make it relevant to the discussion.
I don't see any others. I'm sure Dr. Berry wouldn't mind getting done with his day a little sooner. Yeah, no, it's wonderful, but I'm sure it makes for a very long day for you. And we so appreciate your time. I do have one question though, sort of. I like to throw these out, you know, at the end of these discussions, just because there's so much content and the stuff, you know, we're not oncologists, so it can be a little bit complex for us, but in terms although like we said, and I'll echo what everybody else said, is that this is a very understandable presentation, so thank you for making it such. But you know, in terms of like a take-home message for the patients that are on with us tonight, you know, who a lot of this information might be new to them, you know, what would be important in terms of, you know, the left-sidedness, right-sidedness? I've spoken to patients who really, you know, weren't even aware of what it was considered, you know, their colorectal cancer. I don't know if it was left, it was right. There's a lot of poor communication sometimes, and sometimes it's just because patients, you know, have a lot on their minds and we don't get all the bits and pieces. But what would be important things for patients to be able to bring to their oncologist, to their doctors, to discuss about making sure that they're getting the right kind of attention, making sure that, you know, they've left no stones unturned just prior to hashing out the treatment plan? Would you be able to speak to that a little?
Yeah, I think it's really important, and I think that I think that in general, many, you know, people who show up for treatments are getting more and more informed. But I try and answer the questions or provide the information that I think is important. But I think it's also important for patients to, you know, bring the questions they want and make sure that they're having their questions answered. So I think that from what we're talking about tonight, though, you know, is that when you go to see your, you know, go to see your oncologist, is, you know, first of all, I think it's important, as we've learned in the last little bit, is stage matters, right? So if you're dealing with stage 1, 2, or 3, potentially curative, where we're trying to cure the rectal cancer, the conversations can be different than stage 4. Some stage 4 cancers that have spread are curable, but many are not. And so just knowing your stage and what that means for intent goals of therapy are really important. The next thing is what are the important biomarkers? And for early stage cancer, there really aren't a lot of important biomarkers, but for metastatic cancer, there are some, right? So, and I think it would be like, what do I need to know about my cancer? And is this being done to help you make the right treatment decisions? And the biomarkers, and I teach this to my residents, there's biological, so the important biomarker, when a resident presents a case of a patient to me, I want to know their RAS status, their RAF status, because we have treatments for that, their MSI status, and I want to know what side their tumor is on. So in fact, you have these really fancy biologic tests, but with some very basic education, and this might something that could be on the Colorectal Cancer Canada website, knowing what if you have an idea that your tumor was in the rectum or descending colon, then you have a left-sided tumor. You already know one of your biomarkers. And it's not so important that but to ask about that. And I think that those are the 4 biomarkers that I think you should be asking what side was my tumor on? If you have treatment, stage 4 cancer that is not amenable to surgery, what side was my tumor on? What's the RAS status, the RAF status, and the MSI status? And those are all going to factor into the decisions that are made about your treatment for stage 4 treatment that can't be cured with surgery. Stage 4 cancer that can't be, yeah. So I will, NTRK, NTRK you should ask about. I've talked to many of my colleagues. This is a very rare treatment. And in fact, what's happening now is Harriet Filotter and her team are screening all of our cancers, because we know that there are certain colorectal cancer patients with certain other biomarkers, MSI and BRAF, that have higher rates of NTRK. So we're fortunate to have a lab working on that. The problem is NTRK alterations in colorectal cancer are exceedingly rare. In fact, in all but a handful of very rare cancers are very rare. And so across the country, as I talk to my colleagues, very few of us have seen it, but it is something. It's very rare. And then HER2, I think Barry and I have, yeah, that's right. For HER2, I think we disagree in that I think that HER2 status is important for clinical trials, but right now there are no prospective randomized trials like there are for RAS, RAF, MSI, that show that knowing a HER2 status and having targeted therapy can actually improve your outcomes. Gastric cancer, we know that HER2 overexpressing tumors, randomized trials show that giving drugs that target that can have huge benefits. We don't have that same information for colorectal cancer. So I think that having HER2 tested and getting onto a trial is really important, but as part of the standard treatment, that's not something that I would routinely check for. So I know Barry and I may disagree on that, but RAS, RAF, MRI, and SIDE are important. NTRK, as I said, there have been very good educational programs about that with oncologists, and in Kingston and in many other places, it's the pathologist looking at, because they can get subgroups of tumors based on other biomarkers where they have a decent chance, but I actually think it's probably much less than 1% in colorectal cancer, actually. So it's pretty rare. But if you find it, there are some very effective therapies for NTRK expressing colorectal cancer.
Fascinating. So I think if nobody else has any questions, I think I will take this opportunity to say an incredibly huge thank you, Dr. Berry, not just for being here tonight, but for your incredible work in the area of colorectal cancer. You know, the rates seem to be going down in the older population, but as you know, increasing in the younger population, and knowing that we have, somebody like you rallying behind us is really very, very comforting. And we look forward to many, many new developments in the field, and hopefully you'll come and tell us all about them in the next little while.
Yeah, I'm happy to. Real pleasure. Great discussion. And I'll have to say that we're very fortunate in Canada, because I've been working as an oncologist for a long time now, 25 years, I guess. And first of all, we have the Canadian Cancer Trials Group, which was one of the preeminent cancer trials group in the world. And many advances in colorectal cancer. The first trial, the first trial that showed that cetuximab was available, Derek Yonker and I worked on, and many others across Canada worked on that. The big trial I talked about that looked at chemotherapy and cetuximab, bevacizumab, CCTG trial. So first of all, the work with the Canadian Cancer Trials Group has been really an outstanding group to work with, and we're very fortunate to have them here and to serve the colorectal cancer patients, not only of Canada, but really the world. In Ontario, I've been very fortunate to work with the Cancer Care Ontario program in evidence-based care. And I think that I'm very proud of some of the guidelines that we put out there that are focused on things like whether intermittent chemotherapy are good treatment, intermittent or different combinations of therapy are good treatments for Canada. And we have a very, especially in Ontario, I'll brag a little bit, a very good program at evidence-based care that really generates good evidence-based guidelines. And we're very fortunate to have Colorectal Cancer Canada, because Barry, I was talking about this the other day. I think we must have met at least probably about 20 years ago.
Well, when you just started, in 1998, we incorporated Colorectal Cancer Association of Canada. And yeah. I had in 1998 so for those who don't know, I had metastatic colon cancer sorry, that's our puppy, to a liver and 2 lungs, big puppy. And it was just about that time when we started in actually 1995, when drugs started to get developed, when there was only that 5-FU that you were talking about before. And then all the drugs came along. So we incorporated in 1998. That's when I had my last lung surgery at that time, and that was in Canada. And the world kind of changed. So we've been seeing each other at ASCOs ever since, and in between, on fantastic oncology, real shout out to the work that you've done in creating oncology education, where we publish all of our work when they're accepted, and they seem to have all been accepted, and we have another 2 coming down as well. So
but it really is important, because we've collaborated on educational efforts. We collaborated on the sidedness paper. We're collaborating on a CCTG trial. And I know all of the great advocacy work that Colorectal Cancer Canada has done. So I think that we're very fortunate in Canada to have kind of that trifecta of really high quality trials, really high quality evidence-based guideline work, really great patient advocates and support groups who really want to work together, right? Who really want to work together and who do it. And really committed bunch of people, oncologists, patients, patient advocates wanting to work together. So thanks for having me. And yeah, I think hope to come back in a few more years and talk about even more of the advances that we've made.
But we may have you back before then.
Yeah, I was just thinking a few years, you should totally come back before then. But thanks for your time, Dr. Berry, and we really appreciate your championing for the patients, a real patient-centered approach. So thank you for that.
Have
a good evening. Thanks, everybody. Have a good evening.
Thanks, everyone.
Thanks. Bye-bye.
Thanks, Scott.